always fun to talk to my friend Paul Siegert because I like to he's the Pied Piper of the coming revolution in healthcare benefits, whether you're a company of 1, 2, or 500. And that's what Paul does well, is making sure that whether you're an employer or an employee, that you're getting treated fairly in the healthcare space. And he joins us now. Paul is the managing partner at PCS Advisors. How you doing, Paul?
I'm doing great. How are you today?
Doing well. Hey, I saw a story that brought you to mind, and I thought, oh boy, Paul can wax eloquently on this one because we've talked a lot about the basic model instead of what I call the medical industrial complex or turnstile medicine. You know, you got your card, you and your employer are paying outrageous monthly premiums. Then you pay your copay when you visit the doctor. Then you pay your deductible. And you never get into the insurance. And if you do, then you have a co-insurance on top of it. It's just the cost shifting over the last decade has gone more and more and more towards the poor employee. And it's just been outrageous. So we talk about the model that we've talked about before, and that is where you have sort of this retainer model with your doctor called a DPC, a direct primary care, and then a backstop major medical problem, right? Is that a fair way to portray the way it should be done?
I think so. And of the options that exist today, that's not only what we recommend to many, that's what we do for our own employees.
Right. But a one size doesn't fit all. And that's what you do, is customize things. And that's what, unfortunately, the industry is trying to get us not to do. They're trying to get us one size fits all, do what you've always done, just keep taking it in the pants and deal with it. Well, I want to talk about alternatives, and that is one. But there's a problem sometimes, right? One is these so-called healthcare sharing plans. Can you go into what that means? Its relationship to an authority by the Affordable Care Act, Obamacare,
sure,
and what went wrong in this particular instance.
Yeah. So one alternative that's out there that can be a good form of catastrophic coverage are these medical sharing programs. They started as a religious thing. Mennonites and some others had put together medical cost sharing programs and ministries where all of their members contributed dollars each month to a pool. Actually, it's more like insurance probably than what health insurance has evolved into today. But you would put money into a pool, and then when there were needs, you had health insurance needs, significant needs, not a cold, but your child broke their leg and they needed to have thousands of dollars worth of care. Then you could submit that to the community, and they would take money out of the pool and cover the cost of that procedure. And they actually were kind of a grandfathered in thing by the Affordable Care Act, and were considered actually to be coverage that would get you out of the fine that no longer exists. Although there are a couple of states that continue the fine, New York, New Jersey, California, some places like that. But they too allow for a kind of an allowance for these types of programs. What you have to be aware of, you always have to be a good consumer. And I think that's one of the big problems we have with healthcare today, is in the way that we pay for it, is that we don't encourage good consumption. In fact, we disable good consumption. People consume in terms of copays and deductibles and have no idea what their health plan is paying or being billed for procedures, and sometimes it's crazy. So one of the buyer beware things about these types of programs is they're not traditional health insurance, so they can have some pre-existing condition clauses. And typically what they end up doing is they'll phase in your coverage over a period of a few years for a pre-existing condition that you may have had, and they won't cover it as much year one, maybe zero year one, a certain amount year two, a certain amount year three, and by year four perhaps you're covered fully. And it's just something you need to read and be aware of and say, is this a good fit for me right now? And in this case,
what happened?
It wasn't. All right, and you had a pastor who had a heart condition, and actually he was aware. He and his wife were aware that there was these pre-existing conditions clauses.
He had some kind of an arrhythmia or something, didn't he? I think so. Yeah.
Right. And I think he had to. Yep. And he had to have a procedure done, and had to have it done right now. after already being on the program for a year and a half or so, and I think there was a 2-year period where it was excluded, and so they ended up being subject to some very large medical bills. Because it wouldn't cover. It covered some, 15,000, I think, in this case, but the balance was left to them to cover. So you really have to be a good consumer, and I think we should always be, but we've been kind of trained not to be by the traditional plans that are out there.
The problem, though, Paul, if people want to test the market and test the models that are out there, it's so complicated. I mean, even in the traditional model, like Medicare, my gosh, people that are approaching Medicare, do you want an A, a B, a C, a D, an E, an F, a G, or an Advantage, or whatever? Mm-hmm. I mean, there's a whole industry about advising, imminent Medicare beneficiaries, and so it's so difficult to do that. What are people to do?
Yeah, I mean that's the challenge, is that you have it's so confusing. I have people that have worked for our company and this is what we do, and they still find out long after enrollment, when they have a medical event, that's when they actually find out how their stuff works. Which is not how it's supposed to work, but that's a pretty common occurrence.
Well, these benefit documents are pages and pages and pages, and it's just it's dizzying to look at it.
Yeah, that's another thing we need to clean up. I mean, we need transparency. We need easy, full disclosure of how things work. We need payers to disclose what they pay. We need providers to disclose what they charge. We need all of this stuff. Transparency. If you fix it in one word, it's transparency, because you can't have a free market without transparency. Yeah. And it would be so much. When you think about it, if we had transparency, I just flew to Vegas this week and gave a talk at a conference on how to fix healthcare in 25 minutes, which in and of itself is laughable. But if you had transparency like you do look at parts of our healthcare system that work really well. Procedures where there's no insurance involved, cosmetic, elective, LASIK, whatever. These things, we watch the cost go down and the quality go up over time.
Yeah.
And these providers, there's incentives for them to figure out, how can I do this more efficiently and more profitably and drive my cost down too, so that I attract more customers, and sounds like the free market.
Yeah, yeah.
And that's what we need. And if it were that easy, where every facility said, hey, if you need a knee replacement, we charge X.
Yeah. Now, what's interesting is
shop around.
Yeah, you're right. I mean, you shop around, especially, and the other thing, you mentioned it early on in the discussion, that they don't. The model we're talking about is, there's not the expectation that every first penny of healthcare is prepaid as part of your health insurance, because we don't do insurance in any other realm that way, right? That drives up costs.
Well, I mean, you don't look for your car insurance to pay to change your oil.
Yeah.
I mean, that would be silly. And of course, they would have to charge you a lot more for car insurance if car insurance was responsible to maintain your car. If homeowners insurance was responsible to paint your house every 5 years and replace the carpet when your kids finally got it dirty enough and all that other stuff, all these other insurances would cost like health insurance stuff. Mm-hmm. But we've gotten way off track. It used to be that there wasn't health insurance and you paid cash. I'm one of 6 children. My parents wrote checks to the doctor.
Yeah.
And he turned around and put $100 in each of our college savings accounts to help us get started. And it was like a beautiful free market transaction. But now we've trained the consumer that you have a health insurance card and it just pays for everything. And then we've said it doesn't have to be transparent. And then Affordable Care Act came in, and we turned to insurance companies and said, you can charge anything you want, basically, and you get a 20% markup, and there's no cap. People thought it sounded really great when they said no maximum, no lifetime maximum.
And by the way, we'll subsidize you since
I never saw it hit it.
And we'll subsidize you because now you have community rating, and so don't worry, we got you covered. It's almost like Fannie Mae and Freddie Mac. Yeah, Freddie Mac.
Yeah, if we need to, we'll just print a few $100 billion more, and we'll pump it into the system and subsidize it a little longer.
Yeah, no problem. Yeah, Mitch and Chuck will take care of you. Not a problem. Hey, well, there are some concerns I have, because I've been on both the doc side, the administrator side, the policy side. I mean, I've been in all different environments, urban, suburban, and rural. And I am concerned about transparency. We talk with Patrick Ishmael, who's the government accountability guru at Show Me Institute, a great think tank. They've just released a position paper. And I challenged him a little bit in terms of the transparency, and he used the Oklahoma Surgery Center model, which everyone knows about. The problem is it kills hospitals because hospitals have a different standard of what they have to have much more expensive capacity by law, right? I mean, and they don't have the expectation of payment before the case. But I think this is the answer. If hospitals, they could get their robust payment for their very niche care.
That's right.
Right? Because the money would not be frittered in, I'm sorry, I mean, I'm a capitalist, you know that, Paul, and I'm a market guy. But I think we're frittering away money to tens of billions of dollars of profits for insurance companies who then deny care, both at the doctor's office and at the hospital, right? And so I think there would be enough money left in the system to support those 24/7 emergency and long-term, acute care facilities. Am I wrong?
I think you're absolutely right. I mean, we forced hospitals into the position in a way of doing things they weren't intended to do,
right?
To fund the things they're intended to do.
Oh, that you just said it, man. That's right.
Wasn't that great?
Yeah, that's it. That's exactly
that was
right.
An accident, but
that's exactly right. Could you, Brian? Would you please put this on a promo? We're going to make a promo out of this. That is the way to put it. That's the messaging. Exactly. We're forcing them in order to keep their doors open for the absolute essential, emergent, urgent, and acute care to do what is probably better done more efficiently out on the marketplace.
Right. Yeah, that's right. There's a reason it can be done cheaper in a surgery center, and there's lots of examples of that. A freestanding imaging center. Yeah. So many examples. It's just a very extreme example. I don't know if you and I have talked about it on the show or not, and I apologize if I'm repeating myself, but a rural hospital in South Carolina that turned a wing of their hospital into a prison hospital, and they have all the prisoners come there, and they had to put millions of dollars into security and so on. But they're doing it because they have to survive or they face closure.
Wow.
That is wild.
Yeah.
I mean, we're supposed to be the shining light on a hill, not a country that is forcing hospitals that serve 20% of our population to go to such great lengths to make their books work and pay keep the lights on and so on. I mean, that's ridiculous.
Yeah. I like your idea better than my thought, which is let's just turn them into public utilities like electric companies, and let's subsidize them with the excessive profits made at the lower cost centers. I mean, that's another way. It's a more socialist way of looking at it. But I mean, we've got to do something to protect, because they're playing, hospitals are playing by different rules than the rest of the market.
Well, here's something for you. What about this? If I lived in a fairly rural part of Northern California until recently, and then I immigrated to America. But I was, it was an area where I grew up and farms and so on. Mm-hmm. And about an hour north of there was a town, and insurance companies knew they had so much bargaining power with a hospital up there because it was kind of out there on its own, and they ended up negotiating a multi-year contract to reimburse them less than Medicare. 95% of Medicare. Yep. And then all the good doctors left. Yep. I mean, they crushed this place. And a simple question that I'd like to ask the world and just put out there on the airwaves right now is, if a knee gets replaced in Redding, California, which is where this was, or a knee gets replaced in St. Louis, or a knee gets replaced in somewhere, should the reimbursement vary that widely? I mean, sure, you might need to account for real estate costs and some variations. I certainly acknowledge that. But should it be a 12x difference?
No.
Probably not.
Of course not.
No. And so we end up watching more and more facilities like that get either gutted or closed. And when I looked at it, my experience was coming at it from the insurance angle, the payment model of insurance, which is why I ended up leaving working for an insurer and doing this. But because I just think, while that makes sense on a spreadsheet, I didn't see them charging those people in those communities less in premium. they actually were paying the same or more, and actually it was more than people that bought the same plan design in an urban area. So here they are in this rural area, reimbursing this hospital, basically crushing this hospital, just squeezing it to the point of death.
Yeah, because they didn't have a bargaining advantage. Yeah, right.
Yeah, they had no strength. And then they're charging the people that live there above market rates for the insurance. But then they're taking those dollars out of that area and moving them into an urban area and using them to compete more effectively with their competition in the urban area.
Right.
So they're able then to reimburse hospitals more there and get some advantages from that.
Yep.
And they're able to reduce the premium they charge the customer there to compete with the other.
Yep.
So we have a perverted, that's capitalism run amok. That's not a free market.
That's right. And the government is enabling it. And, like Ronald Reagan said, the most dangerous word you can hear is, I'm from the government and I'm here to help. Well, Paul Siegert is here to help. And you'll want to stay tuned, ladies and gentlemen, because there's going to be more coming from Paul and yours truly as we continue to pull the clothes off that emperor, because he or she doesn't need to have those clothes on, because you're getting the rip job, ladies and gentlemen, and Paul is out to expose it. Paul, thank you so much, man. I appreciate you being with us. Look forward to some more robust discussions on this topic, and maybe we can get employees to talk to their HR department and have some different discussions than the same old in the new year. Hey, all the merriest of Christmases to you, and a healthy and prosperous new year, my friend. Thanks for being with me.
And to you.
All right, there he is, Paul Siegert at PCS Advisors.